Well, drugs are really good if we use them properly, and they can have great effects. They can make you feel way better, they can save lives, they can treat infections, they can treat depression, they can do all sorts of great things. But the reason that a drug is working is that it is having some physiological effect in the body. Some kind of pharmacodynamic physiological change is going on in the body. It's affecting body function. And any drug that's got the potential to work has got the potential to do harm as well, because it's interfering with body physiology in some ways. And this whole field is called the adverse reactions to drugs, or ADRs. So while drugs are really good, remember that medicines can kill as well, if inappropriately used. The most fundamental principle and tenet of all forms of healthcare, identified in classical times by Hippocrates, is first do no harm. First do no harm. We should not be harming our patients. And for this reason, we need to know about the potential adverse effects of our treatments. And in this talk, thinking specifically about the adverse effects of medications. Now, to put this lesson in some kind of context, we want to look at some terms used in pharmacology. Now, a prescribed drug is a drug prescribed by someone trained to do that, someone trained to prescribe drugs, usually doctors or nurses with specialist training. And these drugs are nationally recognised. So in the UK, for example, this will be a drug which is published in the British National Formulary and is officially authorised for medical use. And the converse of that is a drug of abuse or recreation, depending on your perspective. Now, these are psychotropic drugs, and these are drugs people take because they like the effect. So people might smoke cannabis not because they need it for a cure, but because they like the effect that the cannabis gives them. So that would be a drug of abuse or recreation. And of course, alcohol is very much a psychotropic drug of recreation or abuse, depending on how it's used and your attitude towards that. Now, the indication is the reason the drug is given. So morphine is indicated in pain. Fluoxetine is indicated in depression. It is the indication, the reason why you would want to use that drug. And the contraindication is when the drug should never be given. So morphine is going to be contraindicated in respiratory depression. It's when you would not give a drug. Aspirin or some other anticoagulants like heparin or warfarin would be contraindicated in hemorrhagic conditions. It's when you do not give the drug. And a side effect is any effect that the drug has that is not the reason you've given it. It's not the pharmacological indication. It's another effect of the drug other than the reason that we gave it. It is a side effect of the drug. So, as we've said, ADRs are adverse drug reactions. Reactions to a drug that we don't want, that are harmful and unpleasant. Now, drugs can be given sometimes under special precautions. So special precautions is when the drug can still be given, but you've got to be careful and you've got to monitor the drug very carefully. So, for example, if someone's pregnant, we need to be very cautious about drugs. So special precautions means that the drug is not contraindicated, but we just have to proceed carefully with the drug. Interaction is when two drugs that we give interact with each other. So if we give warfarin, for example, with aspirin, or warfarin with paracetamol, or warfarin with ibuprofen as a non-steroidal anti-inflammatory drug, these two drugs can interact and increase the anticoagulant effect of the warfarin. There's an interaction between the drugs. And there can be potentiation interactions as well. Now, potentiation interactions can be good. We can sometimes give two drugs together and get beneficial effects from that. For example, we give multi-drug therapy in the treatment of tuberculosis, and we get a potentiated antibacterial effect. But as we've just seen with the interactions, potentiations can also be harmful. So when we're giving a patient drugs, we're not looking at the one drug, we're looking at all the drugs that the patient is on at any one time. And another form of interaction is inhibition. There can be inhibitory effects. So one drug can inhibit the effect of another drug. And a classic example there is some antibiotics can inhibit the activity of oral contraceptives, meaning that pregnancy becomes a possibility when a woman is on antibiotics, and they should be advised about this and alternative contraception or abstinence applied. The dose of a drug is the amount of the drug given in terms of weight, normally measured in milligrams, but it could be measured in micrograms or it could be measured in grams, but it's the overall dose of the drug is the weight of the drug which is given. And that's going to be given via a particular route. So the route is how we give the drug to where we want it to get to. So very often we want the drug to get into the blood, into the systemic circulation, and one route might be oral, or another route might be sublingual, or another route might be intramuscular, or intravenous, or subcutaneous. It is the way we give the drug. Now, any drug will be toxic if we give it in large enough doses. So a toxic effect is an effect that we will get if we give too large a dose of the drug, or we give a normal dose of the drug for too long. So classically, paracetamol has a toxic effect. It is hepatotoxic. It can damage the liver. Indeed, it can cause liver failure if used too much, if the dose is too high or the dose is prolonged for a period of time. But there can also be tolerance of a drug. Now, tolerance means that the person becomes tolerant to it, in that the same dose of a drug will have a reduced effect. So a classic case here is opiate analgesic. So someone initially might respond to 10 milligrams of morphine, but then after they've been on morphine for a few weeks, they might need 30 milligrams or 40 milligrams or 50 milligrams to get the same effect, because they become tolerant to the effect of the drug. Now, compliance means the degree to which a patient complies with your instructions to take the drug. So if you say take 250 milligrams 4 times a day, and they do take 250 milligrams 4 times a day, they are complying with your instructions. But if they only take 250 milligrams twice a day, when you've told them to take it 4 times a day, that means they are not complying with your instructions, and there is poor or reduced compliance. Now, hopefully it goes without saying that this idea of compliance that we've just mentioned is a bit hierarchical, a bit paternalistic. It's not really the way we want to go these days in healthcare. So rather than compliance now, we aim for concordance, that the clinician and the patient come to an agreement about what the best thing to do is. And this is very nicely described in this David Werner cartoon here, where the doctor's saying, take 2 pills 4 times a day and don't ask questions, condescendingly chucking the medicine down into the pit of ignorance, where the patient is grovelling and grateful. Well, maybe things used to be like that, but let's change things. We don't want it like that anymore. We want the patient to be in the land of knowledge, the same place we are. We don't want a profession to be a conspiracy against the rest of us. We want equality, we want understanding, we want concordance. OTC is another term, just means over the counter, something you can buy legally. Now, what you can buy over the counter legally, of course, depends on where you live. In many Western countries, it's very restricted. In other countries, you can buy pretty well anything you want. But when we talk about OTC here in the UK, and in most Western countries, we talk about things that you can just buy legally over the counter. Now, people sometimes take herbal preparations as well. Now, herbal preparations can work. St. John's wort, for example, has got efficacy in depression, but it also works a bit like an MAOI, monoamine oxidase inhibitor. So it can have side effects. So it's important, if we're giving medicines as professionals, that we need to know if the patient's taking any herbal preparations as well. And the last term on this slide is efficacy. Efficacy is the degree to which the drug works. So if a drug is efficacious, it is having the desired effect. So because drugs can have adverse effects as well as efficacious beneficial effects, we always need a risk-benefit analysis. What is the risk of giving this drug versus what is the potential benefit to the patient of giving the drug? And sometimes that will mean that we look at the risk-benefit analysis and we give the drug. Other times it won't. And people often think that taking drugs is somehow good and necessary, but it isn't always the case. So mum here is saying, do you think he needs an injection? And the health worker's saying, no, all he's got is a cold. He will get better by himself. Give him rest, give him food, give him lots of drinks. Strong medicine won't help him and might even harm him. And this is often true. When people are sick, they often tend to get better on their own, as long as they have fluids, nutrition, good nutrition, plenty of rest, and they have company. And this means we can avoid iatrogenesis. Iatros is Greek for doctor, so an iatrogenic effect is an adverse effect that begins with medical treatment. So ADRs are a form of iatrogenesis, and we want to avoid this. So drugs are by no means always indicated. And this is deeply rooted in so many cultures. People go to the doctors and they expect to get some medicine, they expect to get an antibiotic. And they're not very happy very often if they leave with health advice as opposed to a medicine, as opposed to a quick fix. But often it is our role to give health education and give advice rather than to give medication. So an adverse reaction to a drug is noxious, it is unpleasant, and it's unintended. It's not the reason we give the drug. And there is a causal relationship between the drug and the adverse event. So the drug is given and it is the drug which causes the adverse event. The adverse event is not caused by something else. And these adverse drug reactions can occur with prescribed drugs, over-the-counter medicines, herbs, or drugs of recreation or abuse. So there could be an allergic reaction to antibiotics with a prescribed drug. There could be a bradycardia if someone takes too many herbs. For example, digoxin would cause a slow heart rate. Over-the-counter medicines, aspirin can cause gastric bleeding. Paracetamol can cause liver damage if too much is taken. And there are many adverse reactions with drugs of recreation and abuse, partly because of the drug itself and partly because of what the drug might be mixed with. So opiates, for example, can cause respiratory depression. Hallucinogenic drugs can cause frightening, bad hallucinogenic experiences. Amphetamine type drugs like ecstasy can cause malignant hypothermic reactions. So these adverse reactions can occur with any type of drug that's taken, but the relationship is causal. Now often we divide adverse drug reactions into type A reactions and type B reactions. Now type A reactions can be anticipated and are predictable based on the pharmacology of the drug. So if we know what the drug normally does, then we can anticipate the type A reaction. It's kind of an augmented, that's an exaggerated effect of the drug, that the drug normally has this effect, but it does more so. So the drug's normal pharmacological action is augmented, often with a normal dose. Or sometimes it can be an inappropriate dose if too much of the drug is given. Or if a normal amount of the drug is given, but the patient is unable to eliminate the drug as normal. So people with hepatic impairment and renal impairment who can't excrete the drug as we would normally expect, if they're given a normal dose of the drug, then they can have these overdose type effects, these type A type effects, even if they're just given a normal dose of the drug. So we have to consider the dose of the drug we're giving, whether the patient's reacting to it in an exaggerated way, and if the patient has any impairment of normal drug elimination. Now from this, it might be fairly obvious now that type A effects are likely to be dose dependent. So the more of the drug is given, the more of the pharmacological effect we would expect, and therefore the greater the severity of the type A drug reaction. And type A reactions are more likely with low therapeutic index drugs. Now there's actually a separate video on this series on therapeutic index specifically. But low therapeutic index is when there's less difference between the therapeutic dose of the drug, the amount of drug we have to give to get the therapeutic effect, and the level at which toxic side effects will begin. So low therapeutic index drugs are intrinsically more difficult, slightly more dangerous to give, because we have to get the dose precisely right, because if we give a little bit too much, we can get these type A side effects. Now, type A reactions can also be caused by drug interactions, where we get a synergistic effect between two drugs. One drug enhancing or augmenting the effect of another drug. Or there can be pharmacogenetic predispositions. So if someone's genetic makeup can affect the way that they process drugs, there can be a pharmacogenetic predisposition. So for example, someone might not produce enough cytochrome P450 enzyme in their liver to metabolize a particular drug. Or you might think of indigenous Australians and Americans who lack the dehydrogenase enzyme to break down alcohol, the dehydrogenasing enzymes that will break down alcohol. Therefore, alcohol can have a very toxic effect on these people groups. Or some people might be born with a G6PD, glucose 6-phosphate dehydrogenase deficiency, which again can affect the way they metabolize drugs, slowing drug metabolism down. So there's genetic predispositions. That's why in the future we might have this bespoke approach to pharmacology. That someone's genetic profile is examined and they're given bespoke drugs that work particularly well with their particular genetics. So thinking of some specific examples of type A adverse drug reactions that we can understand based on the pharmacodynamic effect of the drug, based on the pharmacology of the drug we would expect. So when we give opiates, for example, if you give morphine or drugs of that group, then it's not surprising if you get some sedation, the patient might doze off. And we know that they can become constipated, and we know that these drugs can also cause respiratory depression. So these are things we're always looking out for when we're giving the drug. Or we know that warfarin, heparin and aspirin, heparin and warfarin are anticoagulants. Aspirin will reduce the viscosity of the thrombocytes, the platelets in the blood. So all these can predispose to bleeding, because we know anticoagulants like warfarin and heparin are going to cause anticoagulation, therefore bleeding, if we give too much, would be expected. Now, insulin is a hypoglycemic agent. It is designed to lower blood sugar levels. That's exactly what it does. And if we give too much insulin, then the patient can become hypoglycemic. And indeed, just like the anticoagulation effects or the respiratory effects with the opiates, the hypoglycemic effect of insulin can be a life-threatening condition. If you give a patient too much morphine or too much heparin or too much insulin, this can result in the death of the individual. But it's understandable based on the pharmacology, because we know opiates are respiratory depressants. We know warfarin and heparin are anticoagulant, and we know insulin is hypoglycemic. Therefore, we give the drug with care, looking out for these particular predictable side type A adverse drug reactions. Now, ACE inhibitors are angiotensin-converting enzyme inhibitors. And the whole point of these drugs is to lower blood pressure. We give them to lower blood pressure. They are hypotensive agents. So it's not surprising that if we get the dose wrong and we give too much, then they can have a hypotensive effect. And patients can be dizzy and can faint and feel really, really ill because their blood pressure is too low. So the ACE inhibitors are the drugs that end in pril, P-R-I-L. The most common one we use is lisinopril as the first line treatment for hypertension. Or you might think of other hypotensive agents such as calcium channel blockers. The most common one we use there is amlodipine. And again, these are going to lower blood pressure. The whole point is that they lower blood pressure. So if we give too much, then they can lower blood pressure more than we want, and the patient becomes hypotensive as a predictable side effect of hypotensive therapy. Now, beta blockers are going to block the beta sympathetic nervous system. So they're going to reduce sympathetic activity. And because they reduce sympathetic activity, they can cause bradycardia, because an increased heart rate is caused by sympathetic stimulation. So if someone's beta blocked and they have reduced sympathetic stimulation, it's not surprising that they can be bradycardic. If the heart rate falls low enough, this can lead to hypotension, because we need an adequate heart rate in order to maintain blood pressure. And again, we see this very commonly. Patients might be admitted who are middle-aged or perhaps older people with a heart rate of 50 or 55, as you might expect in a young athletic person. But the reason the heart rate is low is often because they are beta blocked. So whenever we see someone with a low heart rate, we always ask, are they on beta blockers? Because it's a predictable effect based on the pharmacology of the drug. Now, conversely, drugs which stimulate the sympathetic nervous system are likely to cause tachycardia. So, for example, salbutamol is actually going to stimulate the beta sympathetic nervous system. It's in a group of drugs called beta-2 adrenoreceptor agonists. An agonist is something which enhances the effect of the receptor, whereas the beta blockers are going to block and reduce the effect of the beta sympathetic nervous system. The salbutamol is going to stimulate the effect of the beta sympathetic nervous system. That's why it can cause bronchodilation, making the bronchial passages wider to allow the passage of air in and out from the alveoli more freely when there's conditions such as asthma, which are bronchoconstricting. But as a side effect, because it's stimulating the sympathetic nervous system, it can cause tachycardia. And this is quite common when patients, for example, we put patients on a salbutamol nebulizer, they'll become tachycardic for a period of time. Or of course, adrenaline, which is epinephrine, is an obvious sympathetic stimulant and will cause tachycardia. Now, succinylmethonium chloride is used to bring about short-term muscle paralysis. So, for example, if we needed to intubate someone, we might give a dose of succinylmethonium chloride to relax the vocal cords, to prevent the vocal cords going into spasm when there's an intubation attempt. And succinylmethonium chloride is actually, it blocks the acetylcholine receptors. It's a nicotinic acetylcholine receptor blocker. So it's blocking the normal transmission of acetylcholine, which normally causes the depolarization of the postsynaptic membrane, leading to contraction of the muscle. So it's perfectly normal. Well, this is the reason we give succinylmethonium, is to cause short-term paralysis. But then what normally happens is the succinylmethonium is broken down by succinylmethonium cholinesterase, a tissue-based enzyme. But some people lack this enzyme and don't break down the succinylmethonium. So the effect can be prolonged, meaning we need to ventilate these patients over a period of time. But But again, it's predictable based on the pharmacology of the drug. We know that suxamethonium is a muscle relaxant, and sometimes it can cause more prolonged muscle relaxation than we would like. But it's a type A side effect because it's predictable based on the pharmacology of the drug. Now, there are other well-known predictable side effects with common medications. So, for example, gastric irritation, gastritis, and bleeding are common with the non-steroidal anti-inflammatory drugs. That's why we should always take them with food. Dry mouth are common with tricyclic antidepressants, also sometimes used for treatment of neuropathic pain. Diarrhea is a common side effect with antibiotics. The antibiotics will kill off the normal flora in the bowel, leading to alterations of physiology. And we also know that antibiotics can lead to thrush, manilial infections in the vagina and the mouth as well for similar reasons. That's killing off commensal forms of bacteria. Some diuretics we know can cause hypokalemia. They will excrete potassium with the increased volume of urine, leading to hypokalemia. So very often when we're giving furosemide, for example, we might give a potassium supplement with that. Now, if someone's had transplant surgery, they'll need to be on long-term immunosuppressants to prevent their immune system from rejecting the grafted tissue. But because immune surveillance is important in preventing cancer, patients on long-term immunosuppressants also have increased cancer risk. It's a known side effect because of the immunosuppressant effect of the medications. Cytotoxic chemotherapeutic agents are going to inhibit mitosis, the normal cell division. This is known. This is based on the pharmacology of the drug. But that's why it can cause gastrointestinal side effects, because the cells which line the mouth and the gastrointestinal tract are mitotically very active. And that's why hair can fall out as well, because it's a fast dividing mitotically active tissue. We know that lisinopril can cause sore throats and coughs. This is quite common. Very often when people start on lisinopril, they'll develop a sore throat or a cough, and we sometimes need to change them on to other hypotensive agents because of this common, well-known side effect. Now, particularly elderly people can be prone to polypharmacy. They go to the doctor with one complaint and they get one drug, they go with another complaint and get another drug, and they can end up being on several preparations all at the same time, and this increases the likelihood that there's going to be drug interactions. So this graph clearly shows that the percentage of adverse drug reactions increases with the number of medications that a patient is taking at any one time. So we always need to keep a patient's medications under review, and if there's any medicines that are not necessary, they need to be stopped as soon as possible so we minimise the likelihood of polypharmacy. Now, 80% or more of the abnormal drug reactions that we see are going to be the type A form of adverse reaction. But occasionally we do get type B reactions, although these are the significant minority of the adverse effects of drugs that we see. Now, the type B reactions, adverse reactions, are bizarre and idiosyncratic. So these reactions are not predictable and they are not based on the pharmacology of the drug. But some people will get them. And the reason some people get them and the vast majority of people don't is probably genetic, although usually these genetic mechanisms are not well understood. Perhaps the best known type B reaction is the allergic or anaphylactic type reaction. Now again, there's a separate talk on anaphylaxis, but in severe allergic reactions you often get skin rashes, you get severe itching, and in the anaphylactic reactions you can get hypotension and bronchoconstriction. So these can be, well, anaphylactic reactions are immediately life-threatening. We usually need to treat them with adrenaline. But they're idiosyncratic. It's difficult to anticipate who's going to get such reactions. Although if you do have an anaphylactic reaction, say to a particular antibiotic on one occasion, then it's likely if that antibiotic was given on a second occasion, we're going to get the same sort of anaphylactic reaction. This is why we always ask all patients if they're allergic to anything. This is fundamental. So before we give any patient a drug, we're going to ask them if they have any allergies and if it's possible they could be allergic to that drug, because we don't want to make the same mistake twice in terms of allergy and anaphylaxis. Now, there can be type B reactions causing skin rashes which are not allergic and anaphylactic type reactions. They can also occur. And we can also get severe cutaneous adverse reactions, so-called scar reactions affecting the skin. There can also be blood disorders, anemia and leukopenia. Leukopenia means a reduction in the number of white cells which would predispose someone to infection. And type B reactions can also include kidney damage. So these reactions are difficult to predict unless the patient has had such a reaction before, and they are bizarre, idiosyncratic, and not based on the pharmacology of the drug. They're an adverse reaction which is not predictable, even if we understand the pharmacology of the drug perfectly. Well, here we see an extensive rash caused by a idiosyncratic drug reaction. And these cutaneous manifestations are sometimes called drug eruptions. Now, other bizarre idiosyncratic type B adverse reactions that we do come across, thankfully rarely, but we do come across them occasionally. Hepatitis, which is inflammation of the liver, and that can lead to jaundice, the yellow discoloration of the sclera and the skin. Sometimes there can be nerve injury, potentially resulting in impairment of vision or hearing, depending on which nerves are involved. Now, particular drugs are associated with particular adverse reactions as well. Discoloured teeth with tetracycline in childhood, for example, or nephrotoxicity is a well-known possibility with gentamicin or lithium. Or teratogenicity. Now, a teratogen is anything that affects the developing fetus, anything that can adversely affect the development of the unborn baby, such as lithium, tetracycline, or the recently well recognised valparate syndrome. So hepatitis leading to jaundice can be a type A or a type B reaction. So the liver cell damage may be dose related, which would make it a type A type reaction, or it can be idiosyncratic, which is a type B reaction. So for example, in antibiotics it can be a type B adverse reaction, which is idiosyncratic, whereas the more type A reaction to paracetamol or alcohol is dose related. Now, thankfully, we don't see this Stevens-Johnson syndrome too often. It's a toxic epidermal necrolysis. Necro means death. Lysis means to break up. So there's death and breaking up of the surface of the skin. Skin and mucous membranes get blisters, rashes and pain. So it's an extreme form of the scar reactions that we talked about before, Stevens-Johnson's syndrome. Another thankfully rare but extreme form of type B idiosyncratic adverse reaction is aplastic anemia after chloramphenicol. Now, chloramphenicol is an excellent antibiotic, but we tend not to give it systemically these days just because of this risk. Now, the risk is only about 1 in every 50,000 cases, but the aplastic anemia is likely to be irreversible and fatal. So there's a pancytopenia and marrow hypoplasia. That means there's a loss of mitotic activity in the bone marrow, resulting in all of the white blood cells being reduced in number, a pancytopenia. So there's going to be a thrombocytopenia, meaning that there's going to be hemorrhagic complications. There's going to be a reduction in the number of red cells leading to anemia, and there's going to be a leukopenia leading to infection. Thankfully rare, but it is a definite consideration, and the reason we don't give systemic chloramphenicol unless there's an extreme reason to do so. So just to give a brief summary of the differences between type A and type B adverse drug reactions. The type A are predictable based on the pharmacology of the drug. The type B are unpredictable, bizarre, and not based on the pharmacology of the drug. Type A are mainly dose-related side effects, whereas type B are not so often dose-related. They are idiosyncratically triggered, often by a very small amount of the drug. Type A side effects tend to have low mortality. We can intervene and save these patients. But although the type B reactions are rarer, there can be a higher mortality. Whereas type A reactions can have a high morbidity, the patients are inconvenienced and can suffer from this, whereas the type B reactions tend to have a lower morbidity, but as we've said, a higher mortality. With type A, very often all we need to do is reduce the dose of the drug so we no longer get the side effects. But with type B, because it's not dose related, very often we need to stop the drug altogether and make sure the patient is not exposed to the drug again in future. Well, you might want to try this test before you click on to the next slide. Classify each of these as type A or type B adverse reactions. So bradycardia with beta blockers is a type A adverse reaction because it's predictable based on the pharmacology of the drug. Whereas penicillin, the pharmacology of the drug does not cause anaphylaxis, it's an idiosyncratic type B reaction. The same with hypothermia or malignant hypothermia after anaesthetics. It's a type B idiosyncratic reaction. Whereas a dry mouth and blurred vision with tricyclics is predictable based on the pharmacology of the drug, interfering with the production of saliva in the mouth. Hepatotoxicity due to antibiotics is an idiosyncratic type B reaction because damage to the liver is not a normal part of antibiotic activity. And hypoglycemia with sulfonylureas, that's a type A reaction because we know that these sulfonylurea drugs such as gliclazide are designed to be hypoglycemic agents. Well, some people realise that C, D and E follows A and B. So some have suggested that C stands for continuing reactions which do occur, that the drug reaction can be continuing over a period of time, that there can be delayed reactions, and that there can be end-of-use reactions as well. The end-of-use reactions is actually quite a useful one, such as rebound anxiety, for example, when someone stops taking benzodiazepines, or rebound headache when someone stops taking codeine.